Welcome to today's webinar, which is called Clinical Guidelines, Mindlines and Knowledge in Practice in Context, presented by Professors John Gabbay and Andrée LeMay. John and Andrée have both been engaged for decades in trying to help clinicians use research evidence. Today, they are going to talk to you about their theory of mindlines, which is increasingly popular among those charged with implementing health service research. My name is Dee Quinn, and I'm the Project Officer from the Cancer Implementation Science Community of Practice, which brings this webinar to you today as part of its education program around implementation science. This program features a series of events, including workshops, seminars, and webinars based on our curriculum in implementation science, and is supported by our resources website, where you can find useful resources and register for our upcoming events online. Before we start the presentation, please note the following housekeeping information. John and Andrée will present their talk and welcome your questions. To ask your question, please use the chat box on the GoToWebinar control panel and press Send to All. Questions will be answered at the end as part of the Q&A. Just as a quick test, can I please get any attendees on the line to just type in chat so that you can access the chat and you can send questions, please? Even if it's just a hello. Just want to make sure everyone can see it. Okay, great. So it's actually coming up in the questions box, which is great. Thank you. John and Andrée, can you see the questions box?
No, I'm afraid not.
Okay.
At least we can't see any typing in it.
That's okay. The participants are definitely typing. I can see it. How about now? Can you see a questions box?
Okay, yeah, got it now.
Perfect. So that's where the questions will come up for Q&A. Thank you so much, everyone who's online. I really appreciate that. So after the webinar, when we close the presentation, a survey will appear on your computer screen. We very much appreciate your time to complete this survey, as your feedback informs and supports our future events and education program. If you miss completing the survey online, you'll also receive the link by email. So now I will hand over the reins to our presenters to get us underway. Thank you, John and Andrée.
Thank you very much. Well, we're standing in our kitchen giving a presentation to you in Australia. It seems a bit strange, but hopefully you'll be able to stay with us for the whole of the presentation and hear what we say. If you find that you lose contact with us or you can't hear us, just send us a message and we'll try and do something about it. So a little bit about us to start off with. First of all, you heard that we're both professors. We've been working in this area for a long time. We work at the University of Southampton, but we're retired now, but continue to carry on working in this area. I'm a nurse by background. I started off as a quantitative researcher and then soon changed into more of a qualitative researcher. The dilemma that I've had throughout my career has been one of being a nurse, I suppose, where often the view of nurses is that they very much work in an obey mode. But I'm afraid I was taught, and my generation of nurses and subsequent ones were taught to question. So I was always really interested about how research got into practice and what sort of knowledge we should use for giving the best care to patients. John comes from a very different background.
I qualified in medicine, but I bailed out of it for a while and worked on philosophy of science and got very interested in social sciences and the nature of medical knowledge. However, I went back into public health and ended up running something called the HTA program, which is Health Technology Assessment, where my job was to help to produce the research findings upon which health technology assessments, and hence the work of NICE, which I'm sure you're familiar with, the organization that advises on which treatments are cost effective and so on. Whilst my history and philosophy of science, HPS background, had taught me that we really can't trust that kind of knowledge very much, and we need to be much more questioning. So I also had an enormous dilemma, but we both had a big shared dilemma, which we started working on together about nearly 20 years ago now. which was the whole problem of the way in which people expected research findings to be implemented. You may well be, some of you, familiar with this, but just let me bring you, in case you're not up to speed, that the traditional rational linear model, where researchers produce knowledge and validate it, and then they do something called knowledge transfer, which is sort of handing a package to somebody and saying, here you are, here's the knowledge, here's some clever ways of getting you to see it and use it, and you're going to adopt it. And when you do adopt it, you'll come up with some more research questions, and we'll go away to our little studies and do it. Well, that's the traditional model, which I'm sure most of you will be familiar with, is as being far too simple and rational and linear. Things are not so unidirectional and individualized, and the whole thing is unproblematized. The whole thing assumes that there's no social or organizational or political context, and it's basically a mess, but otherwise it's fine. We were asked in the early 2000s, in fact in the year 2000, to do a piece of work with services for older people, where we were supposed to gather together communities of practice, and also in another study that Andrée was involved in, working with similar groups in outpatient services. And the idea was to help these groups to sit down and work together, identify a client-centered problem, frame a proper focused question. We would then use librarians and other information scientists, search thoroughly for the relevant evidence that they asked for. We'd help them to appraise its validity. We'd get them to seek and incorporate some users' views, use the evidence to solve a problem, and then redesign services for older people, or these outpatient services in dermatology. And the whole thing was supposed to go along this lovely line, which I'm sure many of us have been trained in, for how to do evidence-based practice. And when we sat them in the groups and we got them to do it, we saw something rather different. We saw this. What actually happened was that people were not simply accepting the evidence and using it sensibly. They were arguing over it. They were reconstructing it. They were sometimes blocking it. They were overestimating its value. They were changing it. They were forgetting it. They forgot they'd done something the week before, and it just happened. Who happened to be at the meeting made the decision as to what happened. And we realized that actually we've been watching this happen in our own lives, professional lives, for many years. And it was interesting to see how unsystematic this work was. So our funders weren't very happy about this, but nevertheless, Andrée, actually on a flight back from Australia to the UK, managed to persuade the research funder that maybe we should be seeing whether this is also what happens in professional groups, because those groups were multi-sectoral. They came from local services, they included local citizens, they included housing people. What we wanted to do in the next study was to say, well, what happens when you get a group of practitioners who are very good and who work together? Do they do the same thing? So we got the funding to do an ethnography for a few months. In fact, we went on for 8 years, because by then I'd retired and I could work for free, and sat and worked with them. Also did a sort of checking ethnographies, if you like, in other settings. We worked in an urban university primary care practice. The main one we looked at was a rural one. Also looked at training hospital in the USA, and at medical student teaching in the UK, because we got interested in how people acquired their ideas. And this work led us to a number of very somewhat surprising findings. The first was very obvious from the very start, that when a doctor in particular, but nurses to some extent, in the primary care practice was dealing with a clinical question, they weren't just being a clinician. They had many simultaneous roles. They had to, of course, do all the things we expect: diagnosing, prescribing, referring to consultants to the hospital, advocating for the patient, and so on. But they also had a managerial domain. They also had to manage their resources, their staff. They had to improve the quality of work. They had to work with the IT system and get it to do what they wanted and improve it. They had to comply with legal and contractual requirements, and so on. They also had a preventive and public health role: screening, disease prevention, health promotion, health education, and they had their own what we call professional domain. It was their job to keep up to date, to review practice, to do teaching and training, to nurture their collegial networks, and so on. And all of these things were happening at the same time, sometimes in the course of a particular 5-minute consultation, which is what we have in the UK sometimes. They were having to play all these roles very rapidly and come to a decision about what to do. but of course the clinical guidelines were just looking at this clinical domain and ignoring the others. So our first finding was this question of how do people cope with multiple simultaneous roles?
Next, we found that people didn't just use guidelines, they used something called Mindlines. And we began to investigate the types of knowledge that they used. Mindlines are internalized, collectively reinforced, partly tacit guidelines in the head that clinicians use to guide their practice. If you like, it can be one person's mental embodiment of knowledge in practice in context. And it's the in context and in practice that are important when we're thinking about the way Mindlines are used in practice. They're flexible, malleable, practical, and most importantly, contextual. In this diagram, you can see some of the input into Mindlines. So you've got local norms and routines, trainers and teachers' norms, tacit or experiential knowledge, practical skills, soft skills, technical skills, heuristics, shortcuts, rules of thumbs, embedded science, the underpinnings of our disciplines, the guidelines that we come across every day, either local or national, or some guidelines that cut across nations, peer values, institutional culture and context, and role models' behaviours. All of these things get melded together into a Mindline to create knowledge that is relevant in practice and in the context in which it's being delivered. So, yeah, just go back one.
Hang on a sec, slight technical problem here. We just need to go back. We've had to set our computer up separately and differently to do this webinar and can't now find where the mouse is. Where's it gone? Okay, I'll do it this way. Bear with us as you stare at our compost heap.
I can't tell you to talk amongst yourselves because you can't. Anyway, sources of evidence particularly found in Mindlines are local guidance, as I said, central guidance. What representatives from different companies, from pharmaceutical companies, for instance, say, what colleagues say, patients' views, and practitioners' experiences and their experiences of when they're together with their colleagues and also their patients. The infrastructure that they work in, the amount of resources that they have, the constraints that they find there, teaching and training, which obviously is ongoing and continuing development, educational sessions and updating that happens when you read journals and magazines, you read newspaper articles, you listen to other media, you read textbooks, you hear from opinion leaders. And we also found something which was quite unusual, and we never really got to the bottom of this. People would say, well, they say. We're never sure what they say was or who they were, but it seemed to be a very important way of saying, well, this sort of knowledge is something that we use in our practice.
The best analogy that we came up with to try and explain what's going on when people are using these internalized guidelines, these what we call Mindlines, was our compost heap, which you've already had a view of, a preview of. All sorts of things go into it. The local opinion leaders' ideas, the national local policy, one's own experience, what the rep said when they came round, what you picked up at conferences and workshops and so on. And it all kind of gets jumbled up together with your own experience and with your colleagues' experience over time and over the length of a career. And what you get is this kind of melding in magically into something that works, something like compost, which does the job, but you can't quite see how it's got where it is and how it works so well. And this kind of transformation of so many different types and sources of evidence was what characterized what we called Mindlines, and which seems to be the way that most professionals actually make their decisions. So the second thing we found in our ethnographic findings, apart from the multiple simultaneous roles, was that people don't use guidelines, they use these internalized Mindlines. That's their knowledge in practice in context, it's very flexible, And it's grown throughout, hence our work with people learning, particularly medical expertise. It grows with your career, with your learning, but it depends where you are, whether you can use that knowledge. Somebody who's been very used to working in Sydney in the hospital might be a superb clinician, but if they were transferred to the States or to the UK to work in primary care, they'd be struggling for a while because they don't know all those other organizational and social and local norms and peer reviews and the people to go to. So you have an adroitness that goes beyond expertise, and that's very much what the Mindlines inform. The next important thing is that Mindlines are not simply individually arrived at. They are arrived at with one's colleagues.
So you can see here, we start off here with somebody's Mindline, and this Mindline is informed and grown by interacting with other people. And likewise, their Mindlines are informed and grown. And together, say if you're working in a multidisciplinary team or a group practice, you can form together a collective Mindline, usually in communities of practice, for instance, and I'm sure you're aware of what they are, but just so you know what we think they are, here's a definition that we've used throughout all our projects, and it's one of Etienne Wenger's. So community of practice is a group of people who share a concern, a set of problems, or a passion about a topic. And they deepen their understanding and knowledge of that area by interacting on an ongoing basis. And the important thing here is the ongoingness, if you like, of a community of practice. They don't necessarily need to work together day to day, but they get together because they find value in their interaction. So they actually value that ongoing interaction that they have. They spend time together, and typically share information, share insights and advice, solve problems, and they help each other. And they do that through something that we've termed respectful dialogue. And it's very important to think about the nature of this, because it isn't just conversation that accepts uncritically people's views. It allows critique to happen. And this is where you are able to ensure that you evaluate and reflect on practice as you're discussing it, so that you can, and one of the criticisms of communities of practice is that it may be possible to have bad practice as well as good practice. So if you're using respectful dialogue and being critical respectfully of people's practice, then it is possible to identify and eradicate bad practice and also to encourage good practice. So some examples of communities of practice that we found in our ethnography were in, for instance, the GP's coffee room, practice meetings where all staff, multidisciplinary staff from the receptionists through to the senior GPs, the practice manager, nurses, health visitors, phlebotomists, anybody who was involved in the work of that practice met together to discuss certain aspects of care. Various subgroups, for instance, the nurses worked in a treatment room and they formed a community of practice there, and then also some specialist groups to get also, for instance, diabetes and asthma. There were local networks that the GPs particularly went to. It's kind of like a dining club, which I'm not quite sure how you would define it in Australia, but I quickly better define it here as getting together over dinner to have professional conversations, and that's it, full stop. Regional and national networks as well, where it might be a specialist group in relation to diabetes, or a specialist group in relation to different professions. And if you want to read some more about it, you can have a look at this book here. But if you don't worry about that. The important thing about these communities of practice is that this is where we continually saw that knowledge was introduced, transformed, and integrated or rejected. A bit like the diagram that we saw in our very early work in the communities of practice around elderly care and outpatients.
So what we've seen so far is that you've got the formal textbook research-based knowledge that people are supposed to be using. You've also got this collective mind line that people bat about, often through sharing stories and telling little anecdotes about their practice and what they did with patients, which is a way of learning where the limits are of what your colleagues think is acceptable and how your colleagues who you respect would deal with something. And that gives you your individual mind line, which you take into the consulting room to deal with this particular problem. But of course, the person you're dealing with also has their ideas that have been grown through what they see about this particular condition and what they've learned from their friends and their colleagues and their neighbours. And they've got their concepts. So in the middle here, you've got a sort of overlap area where you're negotiating what you're going to do in this particular case.
And I remember early on in my career coming across a district nursing sister who told me this story, which has really stuck with me. And it shows how negotiation at the midpoint here actually might occur. So the lady over here is obviously, I'm afraid, clipped in from Google, but it gives you the idea of an elderly lady who is at home. She is visually impaired. She can't hear very well. She can't get around very well. She has a very beautiful cat who she likes to chat to, as you can see in the picture. She's got a very bad leg ulcer, so the district nursing team have come to see her, community nursing team, and they said, we're going to use the best evidence-based dressing on your leg, and we hope that it'll heal very soon and you'll be able to go about your normal day-to-day affairs a little bit more easily. She's very keen to do that because she doesn't like being lonely and cooped up in her house. So she says, great, okay, I'd like that, let's try it. So we have the best formal view, but we also are going to come across a problem in this this story, because what happens when the district nursing team goes back a week later is that the lady's taken the dressing off, and they ask, why has the dressing gone? What have you done with it? And she simply says to them, well, my cat doesn't come and sit on my lap. My cat doesn't like it, so I've taken it off, and I don't have any dressing on. The team realise that if they're going to make any difference to this lady's leg ulcer, then they can't use this dressing anymore, for the simple reason that it's ineffective. Not because it's a bad dressing, it's because the cat doesn't like it. So they use the next dressing down on their list of preferred dressings. Takes a bit longer to heal, but the cat doesn't mind this one and comes and sits on the lady's lap and purrs all the time as usual, and her leg heals. It might take 7 weeks rather than 4, but it's a much better outcome and everybody's happy. So this is an example of a negotiated individual consultation where knowledge is used appropriately for the context in practice, and it gets a desired result for both people.
We want to introduce you now to what we call the guideline implementation game. And it's based on the idea of a pinball machine. And if you look inside a pinball machine, you've got all these little bits where a piece of knowledge which emerges here from the research team, here they are, the star team at the top. And as that knowledge passes through the system, it hits different bits of the pinball machine. And every time it hits something else and bounces, not only does it move in a different direction, but it changes shape, until it's looking like something very different from the original circle that it started with. This made me think of a piece of work that I've been involved with about 20 years ago, trying to introduce a better way of treating heart failure in a particular district in the UK. And wondering why it was that the cardiologists and the hospital teams weren't doing what the researchers knew was appropriate, and what even in the early days of guidelines, what was being promulgated as the guideline. But when we looked at what was going on, there were all sorts of other actors involved. There were the actual things like the hearts and the ACE inhibitors, there were the patients' views, there was the budget, there was NHS managers, there were civil servants, there were national opinion leaders, local opinion leaders, and as it pinged around inside this implementation with all these different actors, it kept changing until by the time the cardiologists, who were obviously involved in this, pinging backwards and forward, by the time they had the knowledge, it had changed, because what a patient means by heart failure is very different from what a manager means by heart failure, which for them is a budgetary problem that needs to be sorted out. Very different from what a GP thinks, a general practitioner in the primary care sector thinks, from what a hospital doctor thinks. And each person has their own particular view of what is appropriate, their own particular local mind lines, their own collective mind lines of their own community of practice. And it's very difficult to have a dialogue between them that enables the final cardiologist's views of what should be done to match in any way what the researchers initially thought. So the work is being transformed.
So the summary of the work so far then, it's not just clinical, but multiple simultaneous roles that practitioners play. It's not guidelines, but mind lines. It's not only expertise, but contextual adroitness too that's an important factor. It's not only knowledge, but it's knowledge in practice, in context. And it's not just individual, but collective mind lines that are important in everyday practice. And it's not unrefined knowledge, but negotiated knowledge that's used every day in team decisions and individual patient care. And it's not knowledge transfer, but knowledge transformation, as the knowledge that, for instance, researchers bring gets transformed into the knowledge that practitioners need to use. So from our talk, there are some practical implications. Knowledge in practice in context, or mind lines, means that every practitioner transforms and uses knowledge differently, but they do that for good reason. So don't just use top-down directives, use participatory, respectful dialogue, maximising existing social processes, for instance, communities of practice or networks, to help practitioners optimise their use of knowledge to get the best results. Don't expect to find raw evidence in practice. It will have been adapted into mind lines and transformed from the evidence that's presented in a paper to something that is, in fact, used in a context appropriately. Don't focus on theoretical knowledge, encourage co-construction, and that co-construction needs to take into account researchers, practitioners, users, and educators. Often we forget the educators in anything that we do. So that research is tied very firmly to knowledge in practice in context. People inevitably meld different types of knowledge. We need to understand that research knowledge can't possibly be the only form of knowledge that's used. So we need to train people to critically appraise and evaluate all sorts of evidence, not just research, so they can optimize their decision making and use of knowledge.
That's the work that came from our Mindlines program of work, which was going on for several years. But we've also recently been involved in trying to help teams in the National Health Service here, the NHS, to improve their quality improvement skills. And a similar sort of thing, really, from the original project that we talked about. The funders expected us to be putting in lots of nice technical stuff to help people to do quality improvement, the stuff that the Institute of Health Improvement in the States will promulgate, for example, techniques of benchmarking and process mapping and Pareto analysis and run charts and PDSA cycles. And we were helping actually very good teams to try to implement these new techniques to some of them. But what we found was that they couldn't actually do that because they weren't working together properly as groups. They didn't have good communication skills. People weren't being assertive and able to talk about the things that they knew mattered because senior people were too threatening. They weren't able to negotiate their ideas. They were lacking good leadership and political skills and team skills. And they were also lacking the ability to learn through respectful dialogue, to learn together, to do collective learning. And we came up with this notion of like a sort of trying to build a pyramid, which isn't on a sound organizational base that supports this work, where you're just trying to build one wall, which is what our funders were expecting to do, when the other two walls are so weak that it keeps falling over and you don't quite know why it's falling over, and it's because you have to develop these skills as well, which is actually quite similar to the idea of the respectful critical dialogue we talked about earlier, where you need to train people to work as human beings working in an organization with knowledge, and not simply to insert technical knowledge as if it's just going to magically work. So there's just a little extra bit of imagery for you to go away from. Thanks very much for putting up with us. It's very difficult to talk to a blank screen or to your own slides. We're normally sort of leaping around the stage and cracking jokes, but it's very hard to do it in your kitchen at night when everybody else has just finished breakfast or eating it. But thank you very much for listening to us, and we're very much looking forward to answering your questions. Is there anybody there?
So if anyone has any questions, can you type them in the question box, please?
Yes, you can get a copy of the slides, Shelley. We'll send one over for distribution.
They'll be put up on the Community of Practice Resources website with the recording of the webinar.
We're going to try and show us now on screen so you can see.
We can see it. Oh dear.
I'll try and move that down.
Hi. Hello, everybody.
Can you see us? No, you probably can't.
We can't see any of you, so we haven't a clue who we're talking to, I'm afraid. And you've got a lovely view of our kitchen. We can see half of a question at the moment coming up.
Okay, we're hoping you can now see us.
We're going to try and look at the questions again.
Can't see it.
Just here.
Questions, yeah.
But we can't see one.
Can somebody read the question to us? We're having trouble seeing it.
Yep, I can read them. So how do you organise a community of practice if people are not engaged in the issue/clinical problem?
That's a really good question. And the answer is probably that you can't very successfully do that until you can get their interest, until you can stimulate them. One of the ways we do that is, for example, to show them the evidence that they are not performing as well as they would like to. Most people go to work because they want to do a good job, and if they're shown hard evidence that there is a problem, they usually begin to try to deal with it once they get over being defensive about the data being wrong and so on. It's very important to allow them to produce those data themselves so that they trust them. It's very important to encourage them to have discussions among themselves. I'm sure Andrée would like to contribute some thoughts here as well.
I think you have to ask yourself why are they not contributing? It may be that they just don't have an interest in the topic that's being discussed. I don't know if you've got any subsequent information you can tap in that we can see if that helps. I'm trying to look to see if there's anything coming up. I think the important thing about a community of practice is that you obviously choose to belong to it, don't you? So if the questions and the topics that you're considering aren't interesting, then you'll obviously disengage. So it's about making people feel as if they have something to contribute and they're interested in that. So
we're just scrolling through to try and get some more questions, but the screen's not very clear. Yes, you're able to get a call. Hang on.
I can read the next one out to you.
Yes, if you wouldn't mind. Unfortunately, we're only
I would
seeing
like
one
to
line.
learn. Okay.
Go on.
Whether particular professions demonstrate different forms of mind lines.
Yes, they do, very much so, because it depends on the kinds of practice that they have and the kind of work they're doing. One of the nicest things that ever happened to us, we were giving a talk like this in Holland, and the bloke at the other end of the room who was doing the IT and doing the projectors and so on came bounding down at the end and said, you know, that's exactly what it's like in my profession. And most people that we talk to in other professions agree that they have their own ways of doing things in context, which is not the same. And in fact, a lot of the original work on this was done by a team in the States who were working with Xerox engineers. So every team, every profession and sub-profession has its own way of dealing with things. And that's where the contextual adroitness comes in as well, because the Mindlines that a group in your organisation have may well be inimical to the people who work in Southampton University Hospital, who have a different way of looking at things and different budgets and different organisation. So it does vary a lot, and you have to be sensitive to that.
But the important thing is when you're a group of people, let's say you're a multidisciplinary healthcare team, although you have different professional backgrounds, you still have things that hold you together. So there's going to be some overlap between your Mindlines, as there will be with your clients as well. So although professional groups may have separate Mindlines, they can come together to form a collective Mindline, as we described, which addresses a particular client-focused problem.
I can see a question here now which says, and forgive me, yes, the next question, we got one line at a time on this display for some reason. Since the means by which the transformation of knowledge is so complex, how can we make sure the best practice is actually translated? Do you want to have a go at that first?
No.
Okay. The transformation of knowledge will vary, and it is complex. I think it's about intelligently having a dialogue with the people concerned and understanding why it is that they have chosen to modify the knowledge, to transform it in the way that they have, and then see whether their colleagues, their respected colleagues who work in similar situations, would agree that that is a reasonable thing to do. It's not for you as an outsider or as a researcher or as a purist to come in and say, we don't think this cancer team's using the right drug. You have to find out why they are using that drug, why they've decided to modify the national guideline, and then make an assessment. There are no right and wrong answers, and you have to guard against allowing us to go back to the bad old days where the person with the loudest voice in the group wins. So that's about improving respectful dialogue. So
really this is about evaluation and benchmarking. We tend to forget about evaluation, but it is about benchmarking your practice against others who you believe have got good results, who give high quality patient care. And also respectful dialogue to make sure that practices are up to date, up to speed, are doing the right thing for the patients. But all the time, I think it's very important to remember that there will be some individualizing of care, and that might be where you see the most difference, because it's about looking at clients and what they would like and need, and individualizing care, if that's possible, to suit those needs.
You also asked, Shelley, what the soft skills that are critical for the competence of the researcher clinicians to have. That's a really good question. I think one has to be self-aware. One has to listen to one's colleagues. One has to be reflective about that. The skills that you lack will vary. It depends on the situation. It depends on yourself and your knowledge. We're doing some work at the moment with groups who are trying to make improvements in the health service, and asking them what skills they think matter. And very often communication skills come out at the top of the list, that people simply are not finding it possible to get their message across to colleagues. And we have to help them. Sometimes we help them to develop their assertiveness skills or their negotiating skills, and so on. Andrée?
Also, when I used to be a researcher clinician, and was one of my first jobs, I suppose, in the late 80s. And one thing that I learned very quickly was to listen to what practitioners are saying to you, and to have some degree of humility. respecting that they also have very important knowledge to divulge to you, and that research evidence can actually be quite sterile and does need modifying in practice. So humility, respectful dialogue, working alongside people, I think, is important rather than working at a distance from them, which sometimes researchers, not necessarily clinician researchers, but researchers are seen to do. We're looking at the next question now.
Have you given much? Sorry, I can't. Have you given much thought to how emotion affects knowledge transformation in Mindlines? Really good question.
That is really interesting, because we do have a group of researchers that we meet frequently who are interested in Mindlines, and that's a topic that is coming up. I think those of you who are aware of the different types of knowledge that people use, aesthetic knowledge, emotional knowledge, ethical knowledge, will realise that emotions do fit in there. Sometimes they're very broad, aren't they? They're about emotions and dealing with the everyday situation that they find themselves in. They might be emotions that are brought about through frustration because research findings can't be put into practice. Because researchers have been too idealistic in the way that they present their findings. But certainly emotional is something that we have been thinking about and will continue to think about it. Because when you go back to those multiple roles that GPs and nurses have, they're often dealing with resources, with people, all the time, with managing workload, and emotions do come into that. So they will affect the way knowledge is used in context.
The next question is from Carl Schneider, and it's a very interesting one, which has been intriguing me for some time as well, which is, how do our ideas fit with Kahneman's ideas of System 1 and System 2 thinking, which, for any of you who don't know, System 1 is a kind of instant, I've just lost the word, senior moment, the immediate jump, the heuristic that people use to cut corners, which often leads to mistakes. And Kahneman spent his whole career showing how people leap to the wrong conclusions very easily, whereas System 2 is our slower, rational system, which we rarely engage because we're a bit lazy and we prefer to just jump to the simple thing that we've instantly seen. Now, obviously that has relevance, as Carl's pointed out, because what we're seeing is something that's kind of a System 1, but rationally underpinned by years of experience and rational knowledge acquisition, debate, examination, audit, and so on. So it's a we haven't really thought this one through properly, but it's a honed way of taking heuristic shortcuts that isn't just about the clinical, but takes account of all those other roles and domains that we pointed out, the managerial, the preventive, the professional domains, and so on. It's a more robust shortcut, and it's one that one shares with one's colleagues and is constantly testing. In the coffee room, when they were chatting about their patients, you often saw a clinician realize that what they'd done might not be appropriate and they need to go away and think about it. And they would go and find evidence and they'd discuss it and they'd debate it. And if you build that into your System 1 thinking, you're less likely to make errors.
Again, really important, goes back to the respectful dialogue, because then you can say, I've made an error, and think about why you've made it. So maybe Mindlines are a way of combining those two systems?
Yes, I think so, but that's something that I'm really keen to think about a lot more, because I think it does fit in with that way of thinking. But of course, Kahneman's always arguing that we should try to avoid the heuristics because they lead us into trouble. But actually, Mindlines don't, and it's why that's different, or they don't always do anyway. They can do. That's why it's such an interesting concept.
Mindlines could lead you into trouble,
yes,
if they're held closely into yourself, and it's in that collective discussion of them that you probably get out of trouble, and in those discussions with your team members and also your patients and their families.
Nicole has asked how, as a researcher, you might be expected to report on the Mindlines as part of a project or manuscript. Well, I guess that depends on what the project is. This group of Mindlines researchers that we meet with regularly now have been struggling with the idea of how you can expose Mindlines, how you can get groups to unpack them in such a way that other people can understand them who aren't actually part of their group, which is actually very hard to do. I don't think it's your job as a researcher, unless you're researching into Mindlines, to try to explain or set out a set of Mindlines. I think it's the practitioners who do that, and it's very implicit. It's often done through storytelling, through allusion, through little comments. It's not something that you'd be able to write into a research manuscript or a academic paper unless you were actually studying Mindlines. Unless,
Nicole, you use your reflective abilities to expose your Mindline as a researcher. I have a Mindline as a researcher which is completely different to my one as a nurse. That's a bit of a shock for everybody, isn't it, including John? So I could possibly expose that in a reflective piece in a report, if that's what I was trying to do. If you want to discuss this more, I suggest you email us and we might be able to help you with a bit more information.
I mean, I think you should avoid, Andrée just said, I have a Mindline. Of course, we all have loads and loads of Mindlines depending on what the problem is that we're dealing with. And that's why they're so difficult to explain and unpack. But I agree. I mean, we all, you know, I have Mindlines when I'm cooking about how to deal with a certain recipe when I haven't got the right ingredients, and you make it work. So Mindlines are a continuing process. They're not a thing that you can just kind of lift out and show somebody.
So Shelley, you ask about Husserlian phenomenological reduction.
Oh, I'll leave that to Andrée.
I knew you would. And I suppose the best I can say is email me, and we'll talk about it in more specifics, I think. But if we're thinking about that kind of experience, understanding experiences, then obviously they would fit there if it were possible to expose them in some way. And it's finding that technique to do that through in-depth interviewing and observation that you'd need to be careful of. Anyway, email me on that one.
Thank you, Nicole. You found it helpful, you say. Not another question, just to thank you for the presentation. Thank you, Carl. That's very nice of you. And
thanks, Shelley.
Yeah, we've
got to the end.
We're thanking you for your thanks now. You've obviously run out of questions.
So it's been great sharing our work with you. Thank you very much for allowing us to do that from our kitchen. And hope you have a really great day at work. Of course, we're going to bed now. And any of you who want to carry on this conversation, then you can get our email addresses. They're on that thank you slide, and we'd love to hear from you. And any of you who think that you can join us in any of our discussions with a group of researchers working in this area, let us know, or have a chat with Anne, because she knows when we meet, although we haven't got a meeting planned in the future.
That's Anne Dadich. Yeah, thank you.
So we can't hear any of you. Hopefully you can hear us. We're off. Bye-bye.
Thank you so much, John and Andrée. Really appreciate you making the time to talk to us today.
That's a pleasure.
Thank you.
Bye.
Bye-bye.
Bye.